Hey guys, it's Matt with AEC. Just wanted to spend a couple minutes talking about one of our medications, which is adenosine. So adenosine is one of our antidysrhythmics. It has a pretty short half-life, right about 10 seconds, so it's in and out pretty quickly. And it's used mainly to treat some of these rhythms like SVT or VTAC, which we'll talk about in just a moment. And a lot of people consider them to be more of like a chemical cardioversion, so we can use those for our stable patients pretty early on. Adenosine is something that is naturally found in the body. It's a natural nucleotide. It's used in the building block components of our DNA and RNA, and also ATP, which we talk about a lot in class, one of the functional energy units of the cell. So we have adenosine receptors all over throughout the body, but this medication in particular tends to work more on those in the SA node, the AV node, and a little bit in the blood vessels as well. So specifically, the indicators for this are it's after vagal maneuvers. It's one of our frontline decisions that we can use for SVT. That rhythm is really something that, for the most part, all we have to do is interrupt the timing of what that rhythm is, and we can hopefully get them out of it. So if vagals weren't enough to kind of interrupt that timing, this is something that we can kind of slow down or cut out conduction specifically through that SA or AV node. Kind of creates this transient heart block that happens so that hopefully we can kind of get a nice reset and get back into a normal rhythm. You'll notice also it's listed as a diagnostic tool also for our like VTAC or Y-tachy rhythms for AHA. And that's because there's a couple mimickers out there. I know VTAC typically looks a pretty particular way, but if you're unsure of it, this is something that we can give because if they are in a rhythm like VTAC, if we give this medication, it just works too high up on the heart. So if it was a ventricular rhythm, we really shouldn't see any change on the monitor at all once we give this medication. Some of the contraindications for this are high degree heart blocks, higher degree, specifically type 2 or second degree and third degree heart blocks. We can also, we need to stay away from this if they have sick sinus syndrome or patients with Wolff-Parkinson-White. So that's typically not a hard contraindication. It's one we usually have to call med control to kind of get permission for, but it's one generally to be avoided for most people. One of the things to look out for us is that on the monitor when we give this, sometimes it slows down conduction, sometimes it pretty much stops it for a bit and cause a few seconds of asystole, so don't be too worried about it. If you see it, it is something that we can expect from this medication, but it's also pretty important that we go ahead and tell our patients of this too. You know, that is something that, you know, this, if somebody's in SVT, they can be pretty nervous, anxious. It's something that those things can cause SVT and kind of lead into it, or SVT, and those high heart rates and those adrenaline dumps can kind of cause that same feeling too. So we just want to make sure we're talking to our patients, preparing for them for those things. So our doses for this, pretty straightforward. We're going to use 6 milligrams IV push, and this is one, remember that half-life is so short that it needs to be a really, really rapid flush. Typically we're talking about getting an IV, an AC, 18 gauge or higher, because we need to get this medication on board as fast as possible. And if that 6 milligrams doesn't work, we can follow that up right after that with 12 milligrams. The PEDS dose is a weight-based dose. That's going to be 0.1 milligrams per kilogram, max of the adult dose, which is 6. And then followed up, if that doesn't work, at 0.2 milligrams per kilogram with a max of 12.